Yeah, thank you. It's an honor to be here representing the ISHLT and the IMAX investigators, talking our work. This is my disclosures. Advanced heart failure with cardiac shock remains a complex, heterogeneous, and time-sensitive disease entity that continues to challenge healthcare systems across the globe. As we have learned in many decades and recent cohorts, escalating doses of inotropes in a patient with advanced heart failure and cardiac shock is associated with exponential mortality. And contemporary care in advanced heart failure with cardiac shock includes the use of temporary circulatory support as a therapeutic bridge strategy that can potentially aid transitions among eligible patients to replacement therapies such as durable ventricular assist devices. There is limited data characterizing longitudinal transitions for patients with advanced heart failure and cardiac shock receiving temporary circulatory support prior to durable VAD, despite increased utilization of both therapies. Intermax patient profiles are commonly utilized, although they have also been shown to be heterogeneous descriptors for severity of illness prior to durable VAD. It also remains unclear whether a pre-implant TCS strategy affects short and long-term survival after durable VAD. And as we have seen in this rapidly evolving field, specific device and clinical phenotypes associated with recovery, replacement, or palliation are yet to be characterized. The specific aims of the study was to describe the global epidemiology of patients with temporary circulatory support, defined as preoperative use of ECMO, intra-aortic balloon pump, and other TCS, which include, but were not limited to, temporary surgical centrifugal pumps, CentriMac, percutaneous transvalvular microaxial flow pumps, such as Impella, and left atrium to aorta centrifugal pumps, such as Tandem Heart, before durable VAD implantation. And also to examine the short and long-term survival of these TCS patients and compare outcomes to their non-TCS counterparts. This is the study design in Cohort among patients implanted in the IMAX registry between 2013 and 2017. Intermax profiles 1 to 3 were identified, receiving continuous flow LVADs and BiVADs. And then temporary circulatory support, and note that temporary circulatory support, as noted, ECMO, intra-aortic balloon, and other TCS were identified, and then propensity score matching was conducted afterwards. This is a global distribution by pre-implant strategy. As you can see, the majority of patients on ECMO were in Europe. The majority of patients receiving pre-implant intra-aortic balloon pump were in the Americas, followed by the Asia-Pacific, and less in Europe. And patients receiving other temporary circulatory support devices, the majority of them were in the Asia-Pacific, followed by both the Americas and Europe. So there is variability globally. In terms of the baseline characteristics by pre-implant, Intermax profile, and bridge strategy, as we can see, the majority of patients classified as Intermax profile 1 receive ECMO. However, as compared to intra-aortic balloon pump and other TCS, the patients were on ECMO were less likely to receive a bridge to transplant classification prior to durable VAD as compared to the other cohorts. In terms of pre-implant loading and metabolic conditions, as you can see, amongst all groups, there were evidence of elevated right heart and left heart loading conditions with impaired myocardial performance. However, in the ECMO group, there was also elevation of markers of liver congestion and liver cytotic function, such as total bilirubin and albumin. In terms of operative data and follow-up, patients on ECMO were most likely to receive BiVAD as compared to intra-aortic balloon pump and other TCS. They were most likely to also receive centrifugal continuous flow LVADs, had a higher percentage of concomitant surgery, higher ICU length of stay, higher amount of time from implant to discharge in days, less months on durable support as compared to the intra-aortic balloon pump and other TCS and non-TCS cohorts. So these are the results. So in patients, this is survival among Intermax patients 1 to 3, stratified by pre-implant TCS versus non-TCS. As we can see, patients receiving temporary circulatory support had an associated lower longitudinal survival. Among patients, also Intermax 1 to 3, stratified by type of pre-implant TCS. As you can see, patients on ECMO, an associated lower longitudinal survival as compared to intra-aortic balloon pump and other TCS, and non-TCS as well. When patients were evaluated only by Intermax level 1, patients on ECMO had an associated lower longitudinal survival as well as compared to intra-aortic balloon pump, other TCS, and non-TCS at 1 and 48 months. When survival was stratified and analyzed by pre-implant ECMO versus specifically intra-aortic balloon pump, patients on ECMO had an associated lower longitudinal survival as compared to intra-aortic balloon pump. This was also seen on patients on ECMO compared to other TCS as well. When we looked at risk factors impacting survival in the multivariable analysis, the patients on ECMO as compared to other TCS, the hazard ratio for early death was significant. In addition to that, we see a variety of metabolic factors such as there are surrogates of renal and hepatic function, such as creatinine, BUN, sodium, pre-implant dialysis, AST, total bilirubin, and also signs surrogates of elevated right heart loading conditions, including tricuspid regurgitation, also were found to have significant early hazard affecting survival. Then we were asked to proceed with propensity score matching, as we're planning to publish this soon in the reviews. And we were able to match ECMO versus other TCS, ECMO versus IBP, and non-TCS as noted. I put that slide just to show the value and the importance of having a statistician helping with the team. And when we look at the propensity score match cohorts, we see the similar signals. Again, patients that ECMO were compared with other TCS. We see that pre-implant creatinine, pre-implant dialysis, sodium, total bilirubin, and central venous pressure had elevated hazard for affecting or impacting survival as compared to other TCS. Similar signals were shown for patients and compared ECMO to intra-aortic balloon pump, ECMO to non-TCS, which again is, I think, wraps up a lot of the preclinical and translational data that we have seen today. So in summary, there are regional differences in pre-implant TCS, with ECMO being most commonly utilized in Europe as compared to other regions. Patients requiring pre-implant TCS had lower longitudinal survival compared to patients without TCS. And I think based on this data, it's clear that pre-implant TCS type confers a different survival. Talking specifically about ECMO prior to durable VAD, patients with pre-implant ECMO were less likely to have an indication for the durable VAD as bridge to transplant. They were more likely to receive VIVAD, had a highest median ICU length of stay, and the lowest median time on durable VAD. Patients with pre-implant ECMO had the associated lowest survival independent of intermax profile, had a highest hazard of early death compared to other TCS and intra-aortic balloon pump. And constantly, and after propensity matching, advanced age and surrogates of impaired right heart load and performance were identifiable risk factors that impacted survival of patients receiving pre-implant ECMO as compared to other TCS and intra-aortic balloon pump. There are multiple limitations of this study. The results of this database are associative and do not imply causation. In addition to that, there's lack of granularity describing diagnostic management sequences, longitudinal clinical, hemodynamic, and metabolic profiling, in addition type and combination of TCS platforms. Other TCS is not further characterized. An assumption is made that all other devices are associated with ventricular loading. However, we're not sure about that. In respect to ECMO, there is lack of knowledge about center expertise, configuration details, such as oxygenation, coagulation flows, and whether a specific LV venting strategy was utilized. In terms of a discussion and further directions, the IMAX registry analysis is the largest global and longitudinal experience of advanced heart failure patients requiring temporary circulatory support prior to durable VAD. Further research in intermax level 1 to 3 patients transition to durable VAD is needed in order to better understand these differences in survival. And I think global strategies across systems of care that focus on early referral of advanced heart failure patients are warranted. And granular profiling with a dedicated longitudinal temporary circulatory support registry could help with rigorous patient selection and clinical trial design in this advanced heart failure cardiac shock cohort. And as we have seen in the talks today, help identify recoverable phenotypes. And I think this is also will serve as an invitation to ISHLT 2020 in Montreal. I want to thank truly a great set of mentors and investigators, which includes Dr. Mines, which is here, Dr. Cower, Danny Goldstein, and others. And just to put everything together, I think when we try to really think about transitions in advanced heart failure, we think about profiles, we think about therapies, we think about transitions, outcomes, but we also need to think about value, and value is something that has been mentioned a lot. It's hard to study, and again, includes the global access to therapies, team approaches, situational awareness, personalization of care, well-being of patients, caregivers, quality of care, cost of care, and real-world data. And as we're trying to better understand value in advanced heart failure and cardiac shock, I think personal experiences need to transition to prospective registries. And of course, going beyond Intermex, trying to profile these patients with clinical hemodynamic imaging, disease-specific data, recognizing the fulminant presentations, and other new novel emerging stages in cardiac shock, such as the SCAI classification, is needed. And from a personal perspective, I think what value means in terms of that search for value in recovery and longitudinal survival, I think we have all seen as caregivers for patients in shock what is the value of truly native heart recovery. And this is just a random Facebook message that I got a couple of weeks ago preparing for this talk, and I just want to share it. It was the first patient that we supported based in medical center, my first institution, with Impella for peripartum cardiomyopathy. And I think the patient 4 years later had a native heart recovery, doing very well. Actually was invited by Abiomed, and I think that was a nice detail of her to recognize. And from a future perspective of registering advanced heart failure and cardiac shock, the cardiac shock working group led by Naveen Kapoor has allowed me to also include data of my daily work into a collaborative when I was in the University of Massachusetts. Right now, at my last day of the University of Texas in Galveston, and hopefully in the future, where it's your house, my new home, Cleveland Clinic, Florida. So thank you very much for being here and staying here.
Thank you very much for this comprehensive overview. It shows the large number of patients, but also the large number of questions we still have to work on in this community. Is there a question?
We heard about a Faustian deal earlier, and I wonder if you could comment. I mean, I'm just looking at this data for the first time, and the ECMO patients are doing terribly compared to the other sorts of support. But on the other hand, UNOS now is sort of driving up. ECMO becomes like the #1 reason to get a transplant. So is that driving the process where people are trying to sort of game the system by using therapies which appear to be more dangerous?
Yeah, I think we're eager to publish this data as truly a cautionary tale, what could be next. I think there's a lot of need also to transplant centers and UNOS to disclose early or as early as possible what has been the outcomes and the granularity of decision making. But I think the US is a special situation that needs to be addressed urgently. I think this data helps. I agree.
So my question is very much related, is, you know, the outcomes are much worse, it looks like, with ECMO. But after all of those statistics that you had, can you actually conclude that ECMO is worse, given, you know, that you know, it's not randomized, and are the patients really the same? I know you did a lot of work there to you know, to look at baseline characteristics, but you think that this is this strong enough to say that ECMO is worse than other forms of support?
There's a lot of I will say no. I would like to know more.
This is the, you know, I mean,
I think it gives a signal towards and justify, for example, efforts on trying to get granular data on shock patients, such as the shock working group, such as Bill O'Neill's effort, other cohorts around the globe that is trying to granularly stratify. Because a lot of these patients, for example, had cardiac arrest, perhaps. A lot of these patients had only access to ECMO. There's so many variables that are impossible to look into this. I think it's also a call to action for early referral, early intervention, situational awareness, recognition of shock early. But I don't think that this, you know, data is enough to make that assumption. I think, you know, it creates an association, hypothesis generating. I think more data is needed, which includes the clinical hemodynamic imaging profiling.
But we need a way to not have to do a randomized. We need this kind of data. We need maybe better statisticians.
That's right.
All right, thank you very much.
Thank you.
Let's move on.